So thank you, Professor, for the invitation to talk about this difficult topic regarding the arthroscopic-guided Latarjet using ground button in recurrent anterior shoulder instability. So this is my disclosure. So my presentation will be structured in this way. We talk about the background of the Latarjet, the indication and the contraindication, screws versus cortical button, surgical technique, and my result. So we know shoulder dislocation and shoulder instability are common issues for us in our practice. They are often associated with bone loss from the humeral side and from the glenoid side and capsular deficiency. Certainly, the experience of the surgeon and his training plays a key role in the choice of the surgery. We know there is a soft tissue procedure like Bankard, il-sax remplissage associated as a technique, dynamic anterior shoulder stabilization, and there is the bone block procedure like Latarjet, Bristow, or Eden-Ibinet. So we know the gold standard in the literature is the Latarjet procedure. So the Latarjet is a fantastic operation described by Michel Latarjet in 1954. He's a French surgeon from Lyon. And this technique is spread in the entire world by Latarjet-Patte and by Gilles Walch. So this operation consists in to cut the coracoid and through the subscapulary split, fix the coracoid with 2 screws in the anterior margin of the glenoid. And this operation associates 3 effects: a bone block effect because the coracoid increases the diameter of the glenoid, the sling effect of the conjoint tendon to reinforce the inferior part of the capsule, and we can associate a soft tissue repair with the C ligament and the capsule. Classically, this operation is performing open surgery, and we fix the coracoid with 2 screws. So the literature show us in the last year there is a clear indication of the Latarjet. It's the gold standard in young patients with contact sport or manual labor profession, and is a gold standard with glenoid bone loss. Glenoid bone loss we assist in the last year to the decrease of this the percentage of the bone loss, and now we are around 10%, and is a gold standard in an il-sax lesion according to the Giovanni Di Giacomo theory of the glenoid tract in il-sax off-tract lesion, and is a gold standard in Hegel lesion or complex capsular tear with poor quality of the labrum of the capsule and in failed previous stabilization, soft tissue stabilization. So the Latarjet is contraindicated in patients with massive irreparable cuff tear, in older population with arthritis, in patients with epilepsy incontinent and with voluntary dislocator, and is contraindicated in locked anterior dislocation. So the Latarjet is a miraculous operation, is a fantastic operation, yes, but the Latarjet is not miraculous. The Latarjet is a complication. Okay, there is the short-term complication and long-term complication. So the 2 main complications involve the coracoid and the screw, and in the literature shows there is about 20 and 30% of complication. So the coracoid, if the position is too medial, we can assist at a recurrence or a subluxation of the shoulder. And if is too lateral, the patient can develop arthritis, okay? And the coracoid can be not healed, and we are non-union and can assist of the recurrence. So the screw can be break, give osteolysis, can be source of pain. The screw bend and give discomfort for the patient. And if there is an inclination, the screw can damage the suprascapular nerve. So for this reason, to reduce this complication, Dr. Lafosse and Dr. Boileau developed an arthroscopic technique to manage the Latarjet. And what is the benefit of the arthroscopy? Theoretically, the benefit is a great accuracy of the positioning of the graft because we have a better visualization. And we can reduce the screw complication. And we know arthroscopy can reduce pain, discomfort for patient. And with the arthroscope, we can treat the associated lesion like a slap, a cuff, tears, a posterior Bankert. Arthroscopy can reduce the skin complication like infection or hematoma and is cosmetic, especially for the girls. With the arthroscope, we can use a guided system, and this with the specific guide, we can improve the positioning of our graft. And we can use an alternative fixation like Bicortical button, and this can decrease the screws complication. So I talk about this cortical button. So the cortical button developed by the company. We have a guide, a posterior glenoid guide, is introduced from the posterior portal and to drill the glenoid. And we use this cortical suture tensioning to with a dynamometer to clamp the piece of the coracoid and the anterior march of the glenoid. So this device is formed with two cortical two cortical button pegged anterior and with a suture high tension suture max braid. When we tensioning this suture with a dynamometer, we transform this flexible system in a rigid bar like a bolt. And we know in mechanic, the bolt is the evolution of the screw. And the bolt is used to clamp to part of bone, to part in this case, or to part of metal. And we know the tightening with a bolt is significantly stronger than a screw. So another advantage of this device is the elasticity of the suture. And this elasticity limits a self-loosening phenomenon. What is the self-loosening phenomenon? So if we apply an external force to a bolt or a screw, it's possible it can be unscrewed. In this case, is the humeral head. Why? Because the external force is applied, it produces a vibration and an elongation of the bolt of the screw. But this elongation is not possible if we have a rigid system. Consequently, the external load is completely unloaded on the bolt with obviously negative effect. So this phenomenon is limited because we have an elasticity of the suture. And the second advantage is the biological contribution with growth factor through the tunnel create to introduce the cortical button. So biomechanically, we can say one cortical button is comparable or superior to screw. So now we talk about the surgical technique. I use the Pascal bullet technique, but I modify in different order of the surgical steps. I use 30-degree scope in B-chair position, and I don't use them without the medial portal. I have two posterior portal, one convention and one additional for the posterior guide, and 6 anterior portal, one lateral portal, okay, one anterolateral portal, one axillary portal, one coracoid portal, one anterior classic, and one between the anterolateral and the axillary portal to manage the operation. So the first step is the joint inspection and the glenoid preparation. The second step is the coracoid preparation and its osteotomy. The third step is the subscapular split, and finally the coracoid transfer and its fixation. So we have a video here. This is a B-chair position, classic B-chair position with the posterior portal. We inspect the joint. We see the big Hill-Sachs lesion and the anterior bankard and capsular tears. So we decide to perform here an arthroscopic Latarjet, and we see in the first step is to open the rotator interval and to remove the anterior labrum and all aspect of the anterior capsule. It's important here to have a landmark at 3 o'clock or 9 o'clock, and we know this is the center of the glenoid, and we work under this 3 o'clock. After we clean all the anterior aspect of the shoulder from intra-articularly, we switch to the anterolateral portal. And now all the surgery performed from this portal. We never change the portal. So we finish the preparation of the anterior march. We remove with debride or all the aspect of the scar tissue under the landmark, under the 3 o'clock. Okay. We take care to coagulate the vessel of the subscapularis. With a shaver or with a burr, we perform now the bone preparation, okay, to decorticate the anterior march of the glenoid, and to have to expose the cancellous bone. And when we are satisfied about the decortication of the glenoid neck and the glenoid anterior march, so we introduce the posterior guide. It's important with a needle to have a very, very flush portal, and the guide is very, very flush to the glenoid. We introduce this hooked guide. We place the hook in the center of the lesion, in the center of our glenoid preparation, and we drill from posterior to anterior, okay, with the key wire and in a sleeve, okay. We drill 4 millimeters, and this is the glenoid tunnel for the cortical button. When we are satisfied, we remove the posterior guide. So this is the second step, is the coracoid step. Now we are in the anterior part of the shoulder, and we need to remove all the subpectoral and all the deltoid bursa, okay, in the anterior part of the shoulder, and the clavipectoral fascia. So with the needle, we define the axillary portal, okay, and the first step is to identify the medial marge of the coracoid, and we perform the pec minor tenotomy. So when we perform the pec minor tenotomy, it's important to be close to the bone in order to not damage the brachial plexus, okay? When After we expose the superior marge of the coracoid to expose the bone, okay, is very important to remove all the part of this the fat tissue, the bursa. The third part of the preparation is to release the C ligament from the lateral part of the coracoid, okay? And when we clean the bursa, the clavipectoral fascia and this soft tissue, is important to know where is the plexus. And the plexus is medial to the conjunct tendon. And if we follow the medial side, if we dissect, we can see the first nerve is the musculocutaneous nerve. So now we prepare the inferior marge of the coracoid. We use a shaver or a burr to perform the decortication of the inferior side. Okay, and we remove the soft tissue and we remove the cortical bone. When we are satisfied, we drill with the same sleeve the anterior in the anterior part of the coracoid. Okay. And we drill, it's the same 4 millimeter button, okay? And we shuttle with, the next step is to shuttle with an orthocord on PDS and to the cortical button in the anterior part of the coracoid. So this is the cortical button, the pegged anterior cortical button. Now we perform, we remove the suture from the coracoid portal and we perform coracoid osteotomy. Okay, we begin with a burr from the lateral side to fragilize the coracoid, and from the medial side to avoid fracture. And we finish with an osteotome to detach, to cut the coracoid. And we see the final, and if we don't satisfy, we can do a final preparation for to decorticate the bone and to have a flat shape of our of the undermarge of the coracoid. Okay, and now it's important to have very mobility and elasticity of the conjunct tendon of the coracoid, and we can release the medial part and be careful with the brachial plexus. So the third step is the subscapulary split. So we define the upper part, the tendon upper part, and we split 2/3 and superior, 1/3 inferior, okay, through the muscle, and to not damage the tendon, okay. So we can use to determine the level of our split, we introduce a posterior V-singer. This V-singer help us to know where is the good level and to split the muscle. So we introduce we remove the switch and stick, the V-singer, and we introduce a posterior spreader 1 centimeter inside the subscapularis, and to expose the anterior march of the glenoid. When when we introduce and when we open the spreader, we expose the anterior march of the glenoid. So we finish the open the subscapularis, and we coagulate to have a good vision of our anterior march. So the last step is the fixation of the shuttle, is the transfer of the coracoid and its fixation. So we pull from posteriorly the suture, okay, and we pass through the subscapularis. We remove the spreader from posterior, and with a probe or with a switch and stick, we use to determine the correct level and the correct orientation of the coracoid. We introduce this posterior button, and when we are satisfied with the rotation and with the orientation of our graft, we perform a knee knot, okay, a knee knot in order to compact and to fix the posterior button from the posterior march of the coracoid, okay. This is a sliding knot, okay, and we control with the scope the good orientation, and we tensioning with the dynamometer from posterior at 100, 125, and we can see the correct orientation with the strong fixation of the graft in the right position. This is a conjoint tendon with the final view. The conjoint tendon is passed through the subscapulary and here in good position, and we see the brachial plexus here is very close to the conjoint tendon, and it's possible in this phase of in this step of the operation to perform a release to check there is no compression of the brachial plexus. And there is now the final view from the articular side. This is the glenoid and our coracoid, our graft. So what about the post-operative care? So this operation needs one night hospitalization. I put the patient in sling, in a sling in neutral position for 4 weeks. The kinesis begin at 4 weeks when we remove the sling, and the return to non-contact and non-throwing sport at 3 months, and return to complete sport activity or work activity at 6 months. So I adopt this technique in 2017. My preoperative evaluation includes X-rays and MRI or arthro MRI or CT scan. And the clinical evaluation includes range of motion and apprehension test and easy score, raw score, and SS view. So I perform a post-operative evaluation at 6 months with a clinical evaluation, and for all the patients, I perform a CT scan in the post-op and at 6 months. So I analyze my post-op CT scan according to the criteria of the French Society of Arthroscopy. In axial view, if the graft is tangent or medial or overhanged. In the sagittal view, is in the subequatorial space of the glenoid. And I analyze the contact area, the contact between the posterior, the angle between the posterior marge of the coracoid and the anterior marge of the glenoid. So I perform 4 48 Latarjet, 46 all endoscoping, and 2 conversion in mini open. The easy score is measured to 4. 3 patients are hyperlax, were hyperlax. The median age was 30 years. I don't have hardware complication infection. I have associated 1 curve repair in a patient. 1 patient had a transitory axillary nerve palsy, and one patient had a persistent of apprehension after 6 months. So the surgical time after the 30 procedure, now it's between 45 and 60 minutes. Is a difficult operation and needs an important learning curve to have a good time in operating in our OR. So my result is good outcome with full range of motion, improve all the score in more than 90%, 95% of the patients. More than 95% the glenoid in the coracoid is in the perfect and good position in the sagittal view. I perform only 1 coracoid is too high, is my first case, okay? If we analyze the axial view, flush to the coracoid in more than 90% of my patient, I have only 3 lateral and 1. And so I have one coracoid position too medial, and this is my mistake because I fix the coracoid in the standing position. The contact angle is complete for all my patients, and we assist in a very good compression. So the graft is healed in more than 95% of my cases. I observe only 1 partial resorption, and I have non-union at 6 months, but without clinical consequence with the patient, for the patient. I observe 2 failures in the case number 25 and the case number 35. The first is an excessive bleeding during the surgery, and I think is dangerous if you don't see the anatomical structure. And if you are in this condition of bleeding, you don't continue. Prefer to stop and to convert to open surgery. And a second failure is a mistake. Because when I perform the Nice knot, I do a mistake, and the day after there is the pull out of the coracoid, and it's important to know very well this knot. So this is the device with the loop inside the 2 cortical button. We consider the post and the pre with the loop, okay. And the Nice knot consists in a half stitch, okay, through the half stitch, and we open the loop in the our pre. We compact the knot, and this is a sliding knot, and we pull in the post, and there is a compression of the knot to the posterior button and to the coracoid. So I convert the day after in open surgery, and my result compared to the literature, I have the same percentage of the accuracy of the bone graft using this guide system, and with the same rate of complication and the same result with use the suture button fixation. So in conclusion, in summary, the arthro button Latarjet technique was reproducible treatment, reliable fixation system in all cases, ensuring excellent positioning, solid compression, and stability of the graft. The system allows graft healing and avoids hardware-related complication. So thank you, Professor, for the invitation, and I'm very proud because I'm the first in my region in the northeast of Italy. I perform this arthroscopic Latarjet using ground button, and it's a success for all the team, the nurse, the anesthesiologist, and my colleague. And I would like to thank the French school because in the last 20 and 30 years, improve our knowledge to do the best and for our passion. And I would like to thank my mentor, Dr. Lafosse, because when I visit him for my fellowship 10 years ago, he opens my mind about shoulder surgery. Thank you.